Okay, we'll just jump right in. We're recording this to the cloud. Tonight is a lecture on overactive bladder, and I'm not here tomorrow, so lots of students probably have a conflict, which is perfectly fine. I'll post this recording on Zoom through the Canvas, so they'll have access to it. Only a handful of students are here right now. Maybe a few more will join, so we'll see. Any questions or follow-ups to last week or any previous lectures or other questions? Okay. So we'll jump right in. Maybe we'll end a little bit early tonight, and that's fine. Regular Tuesday next week will be our final lecture on GERD and the launch of AstraZeneca's Nexium, the replacement of Prilosec. And then the following Tuesday will be the final exam. So tonight we'll talk about overactive bladder. I represented Astellas on VESICARE, sulfenacin, the oral once-a-day agent for overactive bladder that competed at the time with these other agents you see here: Ditropan, Detrol, long-acting, LA, Oxytrol, and Sanctura. Again, as always, there have been other developments, other products introduced since this was done some decade or more ago, but that's fine. It's one of the lessons learned that we're most interested in pulling forward. So, as always, we'll talk about the disease state, the unmet need, then we'll talk about the product pharmacology, and I'll point out to you the key points of differentiation that are key and central to the key takeaways for this lecture. What I like about this lecture is it harkens back to really the origins of modern pharmacology, which arguably are the anticholinergics, muscarinic and other receptor blockers, and this was really, the beginning of modern pharmacology, where glow-dart poison used by the indigenous people of South America were used to paralyze their prey, because we use curare even today for gut stasis in abdominal surgery, so you don't get spasmodic contractions of the abdominal muscle, smooth muscle, during abdominal surgery. And that is highlighted here in 1941 by Griffith and McGill for anesthesia blocking reflex muscle movement, as I just mentioned. And tubocurarine was the main active ingredient in the early prototypical anticholinergic agents back in the day. So I like this as a pharmacologist. This brings me back to the origins of the discipline. Cholinergic blockade is used for a number of different therapeutic purposes. It's used in the antagonists of the muscarinic receptor are used in a wide variety of conditions to inhibit the parasympathetic, the cholinergic parasympathetic activity in the respiratory tract, for COPD, for asthma. Today we'll talk about OAB in the urinary tract, for GI, for motility disorders, for the eye, to reduce mydriasis and cycloplegia. In cardiac bradycardia, slow heart rates. So, in the sinoatrial node, you've got the noradrenergic epinephrine and the cholinergic input. Cholinergic produces bradycardia, and adrenergic stimulates heart rate. So obviously blockade of the cholinergic enhances cardiac rhythm rate, and in the brain as well. With regard to overactive bladder, the definition of overactive bladder by the International Continence Society essentially is a syndrome characterized by urgency, the sense that you gotta go, with or without urge incontinence, in other words, with or without actually becoming wet, and usually accompanied by frequency and nocturia, or the need to go overnight. And nocturia, again, is defined as waking up to urinate, not waking up for other reasons, disturbed sleep, rhythm, whatever, and then you just get up and go to the bathroom because you're up anyway. Now, nocturia is getting up to go. So urgency, urge incontinence, frequency, and nocturia are the hallmarks of overactive bladder from a clinical perspective, in the absence of other pathological conditions, which we'll talk about in a moment. It's a fairly common phenomenon, underappreciated. The prevalence, meaning the general accumulation in a society of overactive bladder, is pretty much the same across the US and the continent. About 17 million people, or about 16.5% of the US or European population, roughly equivalent between men and women. So in order to evaluate a patient for OAB, we look at a variety of factors: the patient's history, physical exam, urodynamics, and occasionally cystoscopy, and endoscopic examination. So let's look at the history. Vascular accidents or coronary artery disease, dementia, vascular disease. Cerebral palsy, brain tumors, Parkinson's, and MS would be other comorbid conditions that would be potentially etiologic in neurological deficits in overactive bladder. There are potentially spinal cord injuries associated with the condition as well that can be diagnosed and ruled out. But we're talking essentially about the parasympathetic muscarinic receptors, particularly the M3 receptors. Remember, this is a function of both specificity, being M3 over M1 or M2, and selectivity to the tissue in the detrusor muscle of the urinary tract of the bladder. But it's also common to the salivary gland. And that's an important point, because you'll see one of the off-target effects, the leading rate-limiting reason for discontinuation of these anticholinergics is their secondary effects off-target on the salivary gland, and dryness, mouth dryness, is the primary reason patients have discontinued these agents. This is a cartoon that shows the physiology of the cholinergic innervation of the detrusor muscle that contracts and causes urination, or controls urination, acting on the muscarinic receptors, post-synaptic M3 and M2 receptors. And this is another cartoon that shows the general distribution of the cholinergic and adrenergic receptors. And you can see on the detrusor muscle, M2 and M3. M2 is about 80% of the cholinergic innervation in the detrusor muscle. Another picture that shows the relationship of the ureter, the detrusor muscle, the bladder, and other relevant organs in the urinary tract. So why should we care about overactive bladder? What's the big deal? Well, it's actually not a trivial condition at all, because patients, the 16.5% of people in the US and Europe who suffer from OAB, have more urinary tract infections by far. And we know that in older folks, urinary tract infections, UTIs, really knock individuals down and make them increasingly frail. And they're twice as likely to fall. They have many more healthcare visits in a year, and they're more likely to self-report their health as decreased in quality. So falling in the elderly is also not a trivial event. Breaking one's hip or other bones in the elderly is highly associated with bad outcomes, mortality. So what is the goal of overactive bladder therapy? Well, Primarily, it's to reduce incontinence episodes. And in that, I mean, patients don't want to be wet. Nobody does. It's uncomfortable, it's embarrassing, it's disturbing. And also, besides becoming wet and having actual incontinence episodes, it's the sense of urgency. You may have seen the advertisements in the past, gotta go, gotta go, gotta go. That's an uncomfortable feeling for people, whether they actually become wet or not. And so decreasing the frequency of urination or micturition and improving quality of life. So these are the desirable objectives of therapy for overactive bladder. Symptoms, when we talk about frequency, urgency, and urgent incontinence, from a frequency, we're talking about 8 or more visits to the toilet in a 24-hour period, urinating at night, and 2 or more visits to the toilet during sleeping hours is overactive bladder. So again, if you wake up to urinate twice or more per night, you've got OAB. If you just have the strong, sudden sensation to urinate, whether you do or not, that's also overactive bladder. And if you actually have involuntary loss of urine, that's overactive bladder. And any combination of these would be considered diagnostic of OAB. There are different types of urinary incontinence. There's urge incontinence, where you have urine loss accompanied by the urgency sensation that results from abnormal bladder contractions. And you've got stress incontinence, urinary loss resulting from sudden increased intra-abdominal pressure, laughing, coughing, sneezing, etc. And the differential is important, as we'll see in a moment, because urge incontinence can happen to anybody, particularly as you get older, but stress incontinence tends to be more associated with women who had children. And there's been a extension or a stretching of the bladder wall, the pelvic wall, due to pregnancy typically. And that is amenable only to surgical intervention if it's serious enough. It doesn't respond. Stress incontinence does not respond to anticholinergic therapy. And that's an important point for you to understand, both now and in the future in your own clinical and research practices. Urge incontinence is amenable to pharmacological intervention, but not stress incontinence. So it's important to have a differential diagnosis so that you don't give an anticholinergic to a woman in particular who has stress incontinence due to pregnancy and pelvic floor abnormalities. Does that make sense, everybody? There's only a couple of people here tonight, which is fine. 12 people. Just jump in if anybody has any questions. It's a small group tonight. There are overlaps. You can have stress, urinary incontinence, SUI, or urge as separate entities, or you can have mixed symptoms and the mixed phenomenon. And so it does get a little bit tricky to differentially diagnose these. Sometimes symptom assessment is enough for medical history and physical exam. So if you've got a strong sudden desire to void, to urinate, that's overactive bladder, typically not stress incontinence. If you've got frequency with urgency, you got to go a lot, that's typically OAB, not stress. If you leak and have wetness, wet incontinence, urinary incontinence during physical activity or coughing, sneezing, or lifting, that's typically stress incontinence, pelvic floor abnormalities. The amount can be quite different. It can be a lot in OAB, but very small in stress, etc. You can see the differentials here. Waking to pass urine at night is typically, as I said, diagnostic of OAB, but not stressing. So symptomologically, you can tell there are significant differences between overactive bladder, which is amenable to pharmacotherapy, versus stress incontinence. And so would mixed generally occur in older women who have been pregnant? Yeah, fair point, Hania. Yeah, you typically would have mixed in a woman who's older, who's had children, and that would be more common in that population for sure, for the reasons mentioned. So where does this sit as a condition relative to others? Well, here you see the 17 million we talked about, right up there with asthma and more than osteoporosis, right up there with heart conditions, a little bit less than arthritis. So it's not an unusual situation. People don't think about it that much, but they should. It does increase with age for obvious reasons, and is fairly evenly distributed between men and women. Wet versus dry OAB, about 2/3 is dry, not urinary incontinence itself, but about a third or more is wet, and very disconcerting for people. How does one diagnose this? Well, as we said, patient history, symptom assessment, physical exam, urine analysis, other infections involved, non-invasive workups, but there are more invasive workups. So they basically considered a hidden condition. Many patients self-manage by frequent voiding, reducing fluid intake, wearing pads. 2/3 of patients are symptomatic for years before they seek treatment. Up to a third of patients seek treatment, receive no assessment, and many are never examined at all. So it is often a hidden condition, unfortunately, underappreciated. Patient misconceptions and fears, they think it's part of normal aging, of everyday life. It's really not that severe or frequent enough. It's embarrassing. But as we saw, it leads to increased falls, increased urinary tract infections. These are not trivial outcomes. So sometimes you've got to look one step beyond the actual condition to understand its severity. I would argue that it's quite a severe situation underlying some particularly bad outcomes in older folks. How does one screen for overactive bladder? Well, clinicians have to ask, do you have problems, bladder problems that are troublesome? And then that leads to a series of diagnostic tests. Jasmine asks, is this tied to waiting to use the bathroom for longer periods of time, muscles becoming weaker, or just old age? So I think overactive bladder may just be a function of age, or just abnormalities in the cholinergic innervation. It's not all. You saw that while the rates go up over time, it's not zero, even in middle age. All right, here you go. Even in the 30s and 40s, it's 20%. It's quite common. Yes, the numbers go up significantly after age 65. It's 55, but it's not zero at all in younger people. Does that answer your question? I'm not sure it does. So you ask the question, and if you get a positive answer that the bladder is causing concern, then you would do some additional screening. You'd look for infections, for stones, for tumors, cystitis, outlet obstructions, diabetes. You think about the medications. Diuretics could cause overactive bladder for obvious reasons. Other commonly used antidepressants, antihypertensives, hypnotics, etc. Pregnancy. I know there are psychological issues. So there are many causes of overactive bladder. Yeah, good, thanks. One would need to do a physical exam, a bladder palpation, check the neurological status, pelvic or potential rectal exams, urine analysis to rule out hematuria, polyuria, bacteremia, glucosuria, etc. So there are plenty of other comorbid conditions that could account for it, but in the absence of those, typically is what we said, OAB. So if it is OAB, you treat for frequency and or urgency, with or without incontinence, and you try for a number of weeks. If you fail, primary care would typically refer to a urologist for a man and a urogynecologist for a woman. Reasons to refer, as we said, to the specialists in this category. For a man, a urologist; for a woman, a urogynecologist. Symptoms don't respond to conservative therapy. There's some blood or other infections upon urine analysis. UTIs are recurrent, pelvic, bladder, vaginal, or other urethral pain, etc. There are quite a number of reasons to refer to a specialist in these conditions. So I'll transition now to treatment options. Behavioral therapy is helpful in this case, but there's good medication, there's combinations of behavioral therapy and pharmacotherapy, and a few other things. And surgery more for stress, urinary incontinence. The pharmacotherapy, and when I worked on this, Timothy had a question? Go ahead.
Yeah, I had a question about the previous slide. I was going to ask, what's the benefits or the pros and cons between each? Because I was looking at behavioral therapy. I was trying to think like if that's what people normally do and it's probably not working, like why would that be an option for like a therapy option when you could just take medicine or do like surgery or something like that?
So if it's not stress incontinence, so it's OAB, and it might be amenable to therapy, pharmacotherapy, which stress would not be for the reasons mentioned. Some of the bladder habits, they call it, are ingrained. So if you're going frequency and you don't have full bladder emptying, then you're training your bladder to go when it's not full. And so bladder training through behavioral therapy is an important component of treatment here. Does that make sense? So if you're getting up at night and you go to the bathroom, your bladder's not full, you're almost telling yourself to wake up when you don't have a full bladder.
Okay.
Same thing during the day. If they call it volume voided, and you'll see that later in later slides, as a clinical study endpoint. You want to have a large volume voided. Normal urinary function would be you empty a full bladder. If you're emptying, Timothy, a partially full bladder, you're training yourself to have overactive bladder. You're training yourself to go too often. Because the more full you are, the less frequently you need to go. If you're going more than 8 times in 24 hours, that's overactive bladder. And you're probably voiding 100 milliliters at a time instead of 300 milliliters at a time.
Mm-hmm.
Right?
Yeah, that makes sense. That makes sense.
That's a good question.
Okay, I appreciate it. Thank you.
You bet. So let me just check the chat, make sure there's other questions. So for children that have issues with bladder control, or those who might have OAB as a trauma, would behavioral therapy be more effective, or would you need to use combined therapy? I'm not an expert in this case. I don't know is the short answer. My suspicion is that the combination of behavioral therapy and some pharmacotherapy for a period of time would be better. But I don't know that from clinical studies or from my own personal experience with this therapeutic case. So I'm just not sure. But my guess is if you've got trauma in particular, depends upon the nature of the trauma. If it's trauma to the pelvic floor, you may need surgery, like if you were pregnant in the past and had a difficult pregnancy. Other kinds of trauma that have nothing to do with the urinary tract may just be a behavioral phenomenon that's been reinforced in a negative way that would respond reasonably well to behavioral intervention. So I think for most of the times, I think if you look this up, why don't you look it up and let us know what is the most effective therapy? I suspect it's combined therapy, and maybe report back to us for a minute next week at the beginning of class. Because I think it's a really good question. I'm just not sure. Yeah, thank you. So lots of anticholinergics in this space. And again, the whole point of this lecture series and this course is, are they all the same? Was Levitra, Viagra, and Cialis all the same? They're all PDE5 inhibitors. No, right? You need to know that they're not all the same. Long-acting insulin's the same? No. COX-2 specific inhibitors all the same? No. I mean, if there's one lesson you walk away from this course, it's that the pharmacological points of differentiation are important, and they do define specific advantages or disadvantages of different agents. Same thing is true here. And that's why I picked this, because there's half a dozen or more agents competing for market share in the business of treating overactive bladder. So let's get into that. And you can see how these were developed since the 1980s into the 2010s. And you see here the early oxybutynin, tolterodine, trospium, solifenacin. When I was first involved, that's VESICARE, solifenacin. And big companies, Pfizer, others, Sanofi, Venice, in this space. Ditropane, oxybutynin, had immediate long-acting forms, 3 times a day dosing, which is insane. They have their once a day extended release, but side effects of dry mouth. You'll see the dry mouth issue come up again and again, because I showed you earlier the off-target effects of the M3 non-selectivity of the M3 antagonists also block the salivary glands. So therefore you don't produce enough water, essentially, and you get dry mouth, which is rate limiting, the primary rate limiting side effect in this category. Same thing here with oxytrol, a transdermal patch, Detrol, VESICARE. We'll talk, it has some dry mouth, but it's going to be a key point of differentiation. Trospium, Sanctura, didn't pass through the blood-brain barrier, so claimed to have fewer cognitive effects. There was at the time the theory of Alzheimer's disease based upon cholinergic dysfunction in the brain. Turns out not to really be the case. But it didn't stop the Sanctura people from proposing that. Enablex, darafenacin, highly selective M3 antagonist, all anticholinergics. But the one thing you learn in basic pharmacology, you may recall, anticholinergics produce the side effects of red as a beet, hot as a stove, mad as a hatter. And so all of them have the potential to cause somnolence, blurred vision, constipation, dizziness, dry mouth, etc. And this is an important slide because it tells you the problem in this category is that prescription persistency, call it 1 month per refill, by the end of the first year or the end of the 11th refills, 85% of people have stopped refilling their prescription. There is something wrong with the therapeutic category when only 15% of patients continue to refill prescriptions of any kind, as you see here. So clearly, by the second refill, you're below 50%. By the fourth, you're down to 28%. By the 11th, it's terrible. This is not a good picture. So VESICARE had come along in 2006 into this crowded marketplace with 5+ agents. Pfizer's a powerhouse. Obviously, they launched other agents, Tobias in 2007, but a fairly flat marketplace with no significant differentiation in physicians' minds among current therapies. They would just switch from one to the other with no particular, just if you failed one, try another. Who knew? Nobody knew why. The key challenge for VESICARE was to effectively differentiate it from the other agents in the OAB category. So VESICARE focused on a couple of key points of differentiation. Superior efficacy, particularly very good continence rates, but very, very good dry rates at 12 weeks and 1 year. They did some head-to-head studies, which you don't often see in any space. High efficacy and very, very good tolerability, very low discontinuation rate at 12 weeks and their extension trial over 1 year with a very long half-life, centromere for 24 hours. And you can see that it's essentially a similar competitive muscarinic M3 receptor antagonist, highly specific for M3. Otherwise, not particularly unique pharmacologically. But they did an awful lot of clinical trials to make their point. They had to do the registration studies and an open label extension for safety. But they did Star and Venus and Sunrise and Volt and Versus, and they buried the competition in data. Now, the registration trial was 12-week comparison, and they found that 51% of incontinent patients taking the 5 milligram reported no incontinence at the end of the 12 weeks versus 38% placebo group, seeing effects as early as 1 month. The same trial extended out to the rest of the year, 40 plus 12. It kept getting better. 60% reported no incontinence taking the low dose of VESICARE or the 10 milligram, and only a 5% discontinuation rate. Now, this is a key point. You need to know this, so please pay careful attention. This will be a question on the exam. That if I showed you the slide that showed that 85% of patients who take anticholinergics or OAB discontinued by the end of the first year, now I'm showing you only a 5%. It means 95% of patients continue taking VESICARE at 5 or 10 milligrams. That's huge, because the primary reason for discontinuation is the rate of dry mouth. Believe it or not, that's a very disturbing side effect. You can imagine your mouth is constantly dry, and even drinking water doesn't seem to help. So having less than 5% discontinuation rate is probably the primary point of differentiation for VESICARE over the other anticholinergic agents in this category. I think that's a really interesting point of differentiation that I want to draw your attention to, because often it's based upon efficacy, and 60% is a pretty good number, but it's, it's a little bit better than the others, but not terrifically better. But I think the discontinuation rate is the home run point, the key takeaway of this lecture. I want you to pay particular attention to that. In these other trials, they looked at different kinds of outcomes. I mentioned micturition frequency, incontinence relief, sense of urgency, warning time, how much time did you have between episodes, again, urgency, bother, how much are you troubled by your bladder severity, health-related quality of life in Volt, and then in Versus, which was a head-to-head trial against a competitor, I believe. You also measured urgency, frequency, incontinence, and nocturia. So quite a number of clinical trials in this space to drive the point home that VESICARE was the better agent. But we'll look at the FDA required registration clinical phase 3 trials, where in the 12-week period, they showed 51% of incontinence patients taking VESICARE at the low dose reported no incontinence at the end of the study episode, a significant difference. But even at 38% is a pretty high placebo rate. Placebo is pretty good at getting this job done. So that's an issue sometimes in these kinds of clinical trials. And this is from pooled data from 2 studies using the last observation carried forward. I think we've talked about this before, but I'll emphasize again. I like LOCF analyses more than completer analyses. Something to pay attention to in your careers going forward. Completers are basically happy campers. Patients who complete the study tend to be happy with the drug. That's not as meaningful to me as a patient who dropped out after the 2nd, 3rd, 4th week, 2nd month, or whatever, and you carry those observations forward, which would typically not be as positive as a completer, and you still see a significant difference. So last observation, for whatever you dropped out, you still count that data. I like that data. That means more to me. I'd like you to pay attention to an LOCF in your careers versus completers. And you should look for that in your analyses of data in the future. As I mentioned earlier, as they did the post-12-week open label, really safety and flex dose study for the extension trial, the numbers got better. It didn't go down, which sometimes that happens in a full-year trial. It went from 51% to 60% reported no incontinence episodes at either low or high dose of once-a-day VESICARE versus placebo. And that's impressive. And if you look at the fine print of the study reports, VESICARE proved efficacy in OAB from urge in urinary incontinence, urgency, and urinary frequency. And this is a table looking at significant reductions in mean micturitions, the number of micturitions compared to placebo. And you can see that the 5 milligram reduced placebo by 1.4. So you picked up another point and a little bit more to 10 milligrams. And you can see it's a fairly large number of patients. Similarly, at incontinence episodes, wetness episodes, you could see the baseline, and it's important to look at the baseline was 2.9. And so you reduced it down to minus 1.5 below 2.9, or whatever that is, 1.4 or something. So it's not to zero. You're still a little bit wet, but less so with VESICARE. Placebo, again, is pretty good here. Pretty impressive placebo change. That's something to look for. What is the effect of doing nothing? Essentially, placebo is sometimes a pretty effective therapy in and of itself. Well, look at the baseline, 2.9, you reduce by 1.1, you're down to 1.9, 1.8 for placebo alone. Here, as I mentioned earlier, I think to Timothy's question, the volume voided. You want to have a high volume voided, showing more bladder emptying. And in fact, that's the case here. The mean change from baseline and volume voided. Baseline is 163.4 milliliters. And you added up to 42.5 milliliters with a 10 milligram dose and 32.3 milliliters, but a much less amount. So this is pretty impressive data. Mean change from baseline and volume avoided. Larger the volume voided, the better bladder emptying. As they did these other clinical trials and looked at other comparisons, VESICARE was non-inferior to tolterodine. So this was a head-to-head against tolterodine, setting up a primary endpoint that was easy to hit, mean change from baseline to end of study in micturitions, so frequency. And you could see that it went from almost 12 to about 9. Very similar in effect with VESICARE versus tolterodine. But they set up this primary endpoint so they could measure and report on other secondary endpoints that they wanted to talk about. That's a common practice we see in the pharmaceutical industry. Not setting up superiority trials, which are harder to prove, requires greater numbers and more greater statistical significant differences. But instead, they set up non-inferiority endpoints so that secondary endpoints can be discussed statistically, ethically. And so you see in the Venus trial, significantly reported reduced number of urgency episodes, the sense that you got to go, versus placebo was significantly reduced. In the Venus trial, the warning time, because patients offered napping bathrooms, so warning time before you actually go. Was significantly reduced by VESICARE 5 or 10 in the 2 trials. Change in mean number of urgency episodes, significantly reduced by VESICARE. And one's perception of bladder condition, how do you feel about it? So this is a lot of subjectivity. And you can see significant improvements in bladder condition with VESICARE compared to placebo, but not zero with placebo. And in the Versus trial, you can see percent change in mean number of urgency episodes from the pre-washout value period. It was also significantly reduced urgency, sense that you got to go, 4, 8, 12 weeks all the way to the endpoint. So we look at differentiation in this space based upon some of the things we've been talking about throughout the semester. Mechanism of action, M3 specificity, tissue, organ, cell activity, some of the side effects related to non-specific off-target effects, particularly in the mouth, salivary gland, dryness, dry mouth, incontinence relief, the number of dry days, improved warning times, safety, reducing potentially the risk of falls in the elderly. And that message was disseminated to a very large audience at the pre-launch and launch phase that I was involved in with the company, to OBGYNs, urogynecologists, urologists, and even to primary care. Any questions about the differentiation? What drove the differentiation? Okay. We did, as usually, want to understand the nature of what the target audience felt about this. So we did both comprehensive literature reviews and surveys of specialists, as well as to patients, and to phone interviews. And communicating to patients about these conditions, like we saw in the previous lecture on the vaccines for cervical cancer and human papillomavirus, are really important issues, because the more patients and primary care doctors understood, the better. You can see on a 1 to 5 Likert scale, fairly high scores across the board in what patients were looking and physicians were looking at in this case: compliance, effective treatment options, speaking with patients, differential diagnosis, and the high interest across the board among urologists, internal medicine, OBGYNs, and FPs in terms of the level of pharmacological options, or the new options that were becoming available, this new wave that came through, that were more potentially bladder specific. So we built educational programs based upon the results of these needs assessments, the effectiveness of the treatment options, patient compliance improvements, the lower rate, dry mouth rate, 95% persist after 1 year, more compliance. And when we interviewed clinicians, you can see what they said, that greater bladder specificity due to increased M3 selective receptor antagonism may well result in improved efficacy and tolerability. That OBGYNs typically don't discuss overactive bladder with patients due to patient discomfort and difficulties with the differential diagnosis, but that newer agents with fewer side effects and equivalent efficacy will be well received. And that urge incontinence, becoming wet, is typically a patient-initiated complaint and greatly underestimated in the primary care setting, and the docs would appreciate learning more about the complex pathophysiology, particularly the value of greater M3 bladder specificity. And I would argue that being more M3 cholinergic receptor specific was a powerful reason to believe in the both efficacy and improved tolerability profile of VESICARE in this space. In and of itself, it doesn't do anything, but it's a reason that clinicians understand the unique value of a drug like VESICARE from an efficacy and safety perspective. And so those were the topics we went forward with in our symposia and medical conferences to these different target audiences, and our slide kits and other material we produced for healthcare providers, which is what I did, talking about the prevalence and challenges in OAB, the pathophysiology and the role of the M3 selective receptor antagonism, an overview of the current treatment options and how well they did, and then looking at the VESICARE profile around its increased bladder specificity, improved tolerability, particularly dry mouth, and looking at some of the preliminary data that we had around nocturia and falls the other way. Because you can imagine an older person gets up in the middle of the night, their chance of falling is much greater than during the day. So if you're getting up more frequently to urinate at night, your chance of breaking your hip goes up exponentially when you're older. And that's what we did. We looked at the different issues that we just discussed around diagnostic challenges, pathophysiology, pharmacodynamics, pharmacokinetics, efficacy measures, last observations carried forward as a powerful and efficacy endpoint, comparisons with which we actually had head-to-head data, and the use of secondary endpoints when those primary endpoints were met. And ultimately, the side effect burden, particularly reduced dry mouth, was fundamental to the differentiation in this space. And that's really the key, I think, one of the big key takeaways for this lecture. The differential of a side effect as a driver of product differentiation from a pharmacologic perspective. You know, there was a pretty, you can see VESICARE is kind of up here in this gold, but it's a very competitive marketplace. Promotional spending was enormous in this space. VESICARE was probably one of the biggest. And the sales, essentially, for Astellas was at the time dominant at over $1.5 billion, nearly $1.5 billion during the course of its patent exclusivity, compared to sales of Pfizer's Detrol and other agents. I don't know what this became. I'm sure that it evolved significantly in the past decade or more since this work. But I think the key point is how we brought the product to market to differentiate it against powerful competitors in a very competitive space using these pharmacodynamics and side effect profile, the M3 specific receptor antagonism, and the side effect profile around dry mouth as the key points of differentiation to address the needs of healthcare providers and patients. And so that's the end of the formal lecture, a quick one tonight, but I'll open the floor for any conversation or discussion before we close out.
I have a question. Do you think that the VESICARE was more tolerable for patients because of the way the instant release dose was like processed by their body versus the other medications? And could that have caused like reduced side effects?
I think the differentiation, Allison, had more to do with the structure of the compound and therefore its M3 specificity, more than its immediate release or extended release formulation. That it just was by nature of the molecule more M3 specific and more selective to the M3 in the detrusor muscle or the bladder, and produced less M3 non-specific effects in the salivary glands, so much less dry mouth than the competitors. So I think it had more to do with the inherent molecular structure and its M3 specificity and selectivity.
Okay. Thank you.
Good question, though. Anything else? I think it's an interesting case. I come back to the role of anticholinergic agents appealed to me as a pharmacologist as the kind of the origins of modern day pharmacology. It's kind of the difficulty of distinguishing between these agents was a real challenge for us, because one could argue that all anticholinergic agents are the same. Many thought that. But we found a way of providing real data to show differentiation through a plethora of clinical trials that supported the clinical differentiation based upon receptor specificity differences and selectivity differences, and therefore fewer side effects. And that's the key takeaway for tonight's lecture. That the mechanism of action, M3 specificity, more selective to the bladder, resulted in reduced rates of salivary gland side effects and dryness, therefore much greater persistency, 95% essentially, versus 85% didn't continue with the other agents. And I think that's a kind of a remarkable outcome for a drug that one would say was not different fundamentally than any other anticholinergic agent. So I think it's a terrific example of how differential pharmacology drove market uptake certainly among specialists, and ultimately the patients who decide by voting whether they take the drug again or not. And they by and large did, which they don't understand M3 detrusor selectivity or specificity, but you do. And the clinicians ultimately did, because we educated them. So it's a great example of using pharmacological differentiation in a complex and crowded marketplace that you'd think otherwise was just Coke versus Pepsi. but it's not. Make sense? Okay, there will be one question on the final exam on this lecture. This lecture will be posted. I'll make it available to everybody because there'll be a lot of students. Many students couldn't make it tonight. I totally understand that. It's no problem. I had to change it because I'm traveling the rest of the week. But next Tuesday, we'll come back to have our final lecture. And then we'll have the exam on the, I think it's the 31st, the final Tuesday. Any other questions? Okay, students, thank you very much for your time. As always, appreciate it, and have a good night.